what interventional pain management is, and then kind of go over how back pain presents itself and some of the options that we have available to help treat you guys for back pain. Also, neck pain is there. I don't know is that a neck pain? Okay, so neck pain in this lecture, I'm going to basically use back pain as an analogy to neck pain, because everything that we do for the neck that I'm going to talk about, we can do for the neck too. So I'm just going to take this and hold this. So interventional pain management is a subspecialty of anesthesiology. You can now be an interventional pain management doc by some other like physiatry or neurology, but predominantly anesthesia is the basis of how we become an interventional pain doc. In general, pain management physicians are experts in musculoskeletal spine pathology. 90% of my patients that I deal with on a day-to-day basis is neck pain and back pain. Back pain being more so just because the general population has a lot of back pain. I'll skip through a lot of these things because I think the main thing we want to talk about is just the treatment stuff. So about 40% of the world develops back pain at some point in their life. 8 out of 10 of adults will have back pain somewhere in their lifetime, and a ginormous amount of care is dedicated to treating back pain and neck pain too. Things that increase our risk for having back pain include elderly, gender. Females have a higher risk of having back pain than males. Heavy lifting, smoking, anxiety, depression, stress, scoliosis, obesity, genetics, all these different things have a part to play in having back pain. When we look at pain in general, and especially back and neck pain, we kind of put it in two categories: structural and non-structural. Structural being the type of pain due to some sort of active problem occurring in the cells, tissue of our spine or neck or muscles. Inflammation, infection, cancer, bone disease, all these things are structural problems. The second part of pain is non-structural, meaning the pain that cannot be associated to some finding that we see in the body. So that is actually issues that occur in the pain processing. So in the pathway from the knee, let's say you have arthritis in the knee, you have pain in there, but after time, let's say it resolved. All the arthritic change, you got a knee replacement, everything is perfect, but you're still having that pain. That is because there are signals that occur from the pain, from the knee, that then go into your spinal cord and brain, and then your brain basically gets stuck in an abnormal maladaptive pattern. And we could see that on functional MRIs. You can actually put patients in that have chronic pain into MRI machines, and you can see them light up in abnormal places where normal non-chronic pain sufferers have normal looking brain MRIs. So I'm not going to talk a large part about that, but just so you know that we, in our pain practice, we discuss that a lot. So a lot of patients that come to us have chronic pain for 60 years, but we try all the different things to knock out all the structural causes of pain, and then what's left over is non-structural, and we have ways to treat that too. Today's topic, I'm just going to talk about the big five, big six things that cause back pain. There's a whole host of different things that, can cause pain in your back and neck, but the main ones, one is sprains. So cervical sprains and lumbar sprains take up about 70% of all back pain. We'll talk a little bit about how discs degenerate and how arthritis in the back can play a big part. In our back pain. And again, this goes with cervical. You have cervical facets, discs, same thing as lumbar, so they're both applicable. Disc herniations, another 4%. I forgot to tell you the percentages, but lumbar sprains greater than 70%, 80% roughly, I would say patients, 75% of your pain is probably muscles, ligaments, tendons. Discs and facet joints, those are 10%, so arthritic degenerative changes are 10%. Then you have disc herniations, fractures of the spine, spinal stenosis, and sacroiliac dysfunction. Those are the big guys. 97% of all back pain can be structural back pain. It can be put into that category. Healthy spine, this is what it looks like, but as we age, it doesn't look like this. Things change all over the place, and that can cause back pain too. So the first thing we're just talking about is the sprain part of it: muscles, ligaments, tendons, strains, sprains, and inflammation. Normally, a lot of people, when they think of sprains and strains, they're associated about lifting something heavy or all of a sudden feeling this pain, but they feel like this pain should go away within a couple of days. But that's not really true. Whenever you have a sprain, or the inflammation actually may resolve after about a week or so, but prolonged nerve pain can occur still, and spasms of the muscles and things can go on for up to 3 weeks, 3 months, even longer sometimes. Sometimes people hear a pop in their back and they misinterpret that as maybe I blew out a disc or something, but that doesn't necessarily mean that. Your ligaments and tendons, they move, and so they can flip-flop on each other and cause that popping feeling sensation in your back. Usually, it's better with rest. Stretching improves the treatment for it, and usually, like I said, resolves 2 to 4 weeks, but can take months. If you touch in your neck or touch in your back and it's tender, that's a good sign that your problem is superficial. That means you can't actively touch in your neck or your back to push all the way deep down the spine to figure out whether you got spinal pain, but you can touch, and if it's tender, that means it's superficial. It's something soft tissue. The solution for that is core strengthening. So neck exercises, pulling your neck back and forth, that can help with that. Your back as well, working on your abdomen and your back muscles can help. You have to do a little exercise, physical therapy, even small movements can help with sprains and strains, daily stretching, and just avoid going crazy on the weekends or, doing something that you normally aren't active in doing. Avoid those things unless you get kind of prepared to do those things. What we do for that, outside of ordering, physical therapy for this, massage treatment is good. We do something called trigger point injections. Those are injections where we're under ultrasound guidance. We're putting in a little bit of local anesthetic and a little bit of steroid into the muscle tissues that are inflamed and the ligaments and tendons. And then we do that in a series. So when you have like neck pain or strain, you'll come in and see us while you're doing physical therapy. How are you? We'll do physical therapy in conjunction with those trigger point injections. So if you've ever had dry needling before with therapy, it's similar to that, but instead we're putting in the local anesthetic and the steroid. And steroids are anti-inflammatories. So that anti-inflammation helps remove some of the inflammation from the sprain. We usually have you go to physical therapy right after, because once we put the medication in, we want to pull on those muscle fibers and ligaments and tendons to hopefully keep them stretched as they heal with therapy. And then we have you come back in about a week or 2 weeks afterwards, and we do a series of these injections if you get better. Now, if you're not getting better after that, then we start looking at structures deeper. So as we got a sprain going on in the neck or the back, you did the therapy, you've done the injections, but you're still having that deeper pain. Then we start looking into other locations there. But anyway, when you get a sprain, the best thing to do is 1 to 2 days of rest. We call it RICE, rest, and then inflammation, ice, and anti-inflammatories like not Tylenol, but ibuprofen or Aleve. They're great for that. And then I can give some muscle relaxants. Sometimes that might help too. So the next part of it is we're going deeper from the soft tissue in our back or neck. We're going further into the spine. Now we're looking at the arthritis in the spine or the disc. First one is facets, and those facets are on the back part of our spines. That's what helps us to bend our head backwards or bend our neck or low back. It also helps us rotate. But a lot of times we get arthritis in here, and that happens. Is this a touchscreen? Oh, okay. Can I go this way to go backwards? Well, all right. Look at this. Okay. This is nice. Technology. Okay. So the arthritis in our backs, the facet joints are in the back part of our spines. And as we get arthritic, it's just like a joint, just like in anywhere else in our body. It has a capsule, just like our knee does, just like our hip does, surrounded by fluid. And there's multiple facet joints all along each vertebrae. So you have 2 facets for each one. And as you bend backwards or turn, if you're pushing and pulling on these joints, it can cause friction and cause pain. So, okay, there we go. Just an MRI image of a healthy facet joint. That's a synovial fluid in the joint. Here you can see it's compromised, and on the left is just a depiction of what it looks like, what the MRI looks like. But so you can have active pain just from arthritis from the spine. So people that have back pain and neck pain associated with facet syndrome or facet arthropathy or facet arthritis have predominantly neck pain and back pain. It doesn't go shooting down the legs like you would if you had a pinched nerve. It's deep, dull. It's usually worse in the morning. We usually diagnose it because it's worse when you're bending backwards, worse when you're sitting, when you're driving. Patients that are golf swings, baseball swings, those things that are rotational also cause that kind of pain. And usually moving helps. Standing up, walking, those kind of things actually improve the pain. First line of treatment is anti-inflammatories, where we can give maybe a steroid dose pack that might help alleviate some of the arthritis. Just if you have like joint knee pain, sometimes we'll prescribe a little anti-inflammatory to help, and that's the same thing with your back. Physical therapy, movement modification. Maybe you can't golf. I mean, unfortunately, we want you to golf, but that's the thing that might happen. And then things that we could do to treat. These are everything that's underlying are things that we do as an interventionalist. I'm trained to do minimally invasive procedures, minor surgeries, and injections to help treat your pain. We do globally treat pain, so we do medication management, we prescribe physical therapy, we do pain psychology, but we also, for me, is the interventional side of things. So anything underlying means things that we can do as a treatment option. Radiofrequency ablation and something called peripheral nerve stimulation. So radiofrequency ablation, if you've ever heard of anybody getting their nerves burned, I don't know if that sounds familiar to any of you guys, but that's what we're doing. Each one of these facet joints that we talked about earlier have nerves that go to those joints. Like in your neck, you have them, and in your back, you have them. So instead of treating the joint itself, like if you had arthritis in the knee, it's just easier for me to explain with the knee. If you have arthritis in the knee, just like you would in the facet joint, you can either stick a steroid in there and get a cortisone injection into the knee, or what we do also, we can burn the nerves that go to the knee. So you still have arthritis in the knee, but we've knocked out the connection between the knee and the brain because we've severed the connection, the nerves. So that is the same thing for your joints in your back. We knock out the nerves that go to each individual facet joint, and then the nerves grow back, but they take about 8 months to 12 months or so for the nerves to grow back. And then that can relieve your back pain just, because those joints, they're arthritic, but they're not really causing that much pain anymore because we've knocked out the connection. And that's called a radiofrequency ablation. There was a good study, the Dreyfus study, that showed that after 12 months, 80% of patients still had 60% improvement in pain after radiofrequency ablation, and 60% of that population had 80% improvement in pain. So if their pain was 10 out of 10, 60% of that population in the study had 2 out of 10 pain for the entire year. So they work, you just have to do them correctly. Like I said, the nerves may regrow. I was going to show you this. Does this work if I touch it? Oh, man. Oh, okay. This is nifty, I'll tell you what. Oh. What do you think, Jason?
Radio frequency neurotomy
look at
of the
this.
lumbar facet. This procedure uses heat from radio waves to treat painful facet joints in your lower back. It eases pain that isn't helped by medications or physical therapy. To begin, you lie on your stomach. You may be given medicine to relax you. We numb the skin and tissue of your lower back. Next, we guide a tube called a cannula to your spine. A video X-ray device called a fluoroscope helps guide the tube to the medial branch nerves. These tiny nerves carry pain signals from your facet joints to your brain. Now, we push an electrode through the cannula and down to these nerves. We test its position with a weak jolt of energy. If this recreates your pain, we know it's in the right place. Then we heat the nerves with radio waves. Heating them blocks their ability to carry pain signals. We may need to treat several nerves. When it's done, you get a small bandage on your skin. You're watched in a recovery room for a brief time. Then you can go home. You may feel sore and you may still have back pain, but you'll gradually feel pain relief. This can take several weeks.
Okay. The other thing that I want to talk about, which I don't have a video for, but it's called peripheral nerve stimulation. So there's something called spinal cord stimulation, which we'll talk a little bit about, but there's also something called peripheral nerve stimulation. If you've ever had a nerve block before for surgery or whatnot, that's anesthetizing, knocking out different nerves for, like, let's say you had a shoulder surgery, we do a block in your neck and it knocks out your arm for the surgery. Peripheral nerve stimulation does the same thing where if I was to put the stimulator in your neck, you would have a stimulation in your arm. There are there's new products that are coming out that have been around, but we're now doing them here at Edgerton with peripheral nerve stimulation. And you can use this application for multiple things, including joint pains, occipital headaches, neck pain. I don't know if your neck pain is associated with headaches as well, but that can be treated too. It also is a treatment for back pain and neck pain in general. So even if your problem is coming from discs and facet joints, a stimulator can be placed in your back, and it's temporary. So we put the stimulator, 2 little electrodes that stay outside of the skin, and we tape it up, and you basically at home use the device for 60 days. The trials have been conducted now for 2 years, and the treatment period is for 60 days. You put the little electrode on your side, and you turn it on for about 2 hours a day. The more, the better that you can do. And it stimulates a sensation in your back and causes the muscles of your back to twitch. And it's not like a TENS unit. If you've heard of a TENS unit where you put the little pads on you and it zaps you, it's not that. But it's different, but it is something that we are bringing into the hospital for treatment for all sorts of conditions. So it's called Sprint PNS, peripheral nerve stimulation, and we can talk more about it. But just know it's like the ablation, but it doesn't kill the nerves. It doesn't knock out the nerves. It changes the way that our brain perceives the signal of pain. Okay, discogenic problems. So everyone's heard of degenerative disc disease. If you see it on the MRI or you've heard that I have degenerative disc disease, it's not really a disease. It's just over time, our discs degenerate. And that's part of our humans and other animals. The discs get smaller and they shrink and they get wider. Also, you start getting changes in the bone between. So you're normally up here, this is a nice big plump disc. The discs are shock absorbers of our spine. I think of them as jelly donuts. The outside part of is the dough, it's tough, and then you have the jelly inside, and it's our cushion. So when we're jumping up and down, those discs have support. But as we get older, these discs start to flatten, they get thinner, and turn into pancakes. So that's what degenerative disc disease is. The issue is that as the discs widen, there are some nerve receptors on the outside part of the dough, of the donut, that as they stretch, it can cause pain. So unfortunately, there's not too much good treatment out for degenerative disc disease. At some point, sometimes you can end up getting a fusion. There are treatments that we've done in the past that haven't really, evidence-wise, hasn't shown out to be that effective, where we burn those nerves inside the discs. But things are coming out, and like I just mentioned, the peripheral nerve stimulator can be used for disc problems too. So that is something that's just come out more recently. But anyway, most times people have these disc changes in their spine. They don't really have any back pain or anything, really pressing that in general population. But some patients do have 10-20% have back pain just from discs as well. So when you do have disc problems, and this is normal disc, you can have degenerative disc, you can have bulging disc, discs that herniate, which is jelly leaks out of the back, thin disc, and then you have osteophytes or bone spurs that occur. This is just showing examples of disc problems. But people that have this kind of problem, usually it's worse with bending forward, as opposed to facet issues worse with bending back. Disc problems are usually worse with bending forward because you're putting more stress on the disc. Usually it's improved with laying down, relaxing the spine, putting a pillow underneath your knees, walking or reclining. And this is just showing pictures of what normal discs look like on X-ray and what it looks like, MRI, and what it looks like as a disc herniates here on the side. This is your spinal cord in the middle. When it herniates, that's a problem. That's whenever, if it contacts a nerve, that's when you start feeling pain in your arm or feeling pain in your legs because it's touching a nerve. This is what I was talking about. This is the jelly on the inside. As it leaks out, there's nerve receptors on the outside of the disc that can cause pain. When it herniates, this is the problem you get. You get sciatica or radiculopathy. And it happens in the neck or the back. When you have pressure, mechanical or chemical on a nerve, the nerves don't like it. They get angry and they cause pain. So treatment for that kind of situation, like you probably have heard of some people that have had epidural steroid injections for pain that goes down in the leg or arm. That's the treatment that we do initially for radiculopathy. Usually one-sided if a disc is on one side. Both sides can happen if the spinal cord itself gets pushed, but usually for disc problems, it's one side. If it gets severe enough, you can have weakness in the leg, you can have numbness, tingling, pins and needles kind of sensation. Those things are all associated with compression of the nerve. Again, we start with medications and physical therapy up front. Anti-inflammatories are good. We also use certain medications like gabapentin or pregabalin to help with nerve pain, physical therapy to core strengthening. And then what we do here is epidural steroid injections. This is where we place needles into the area where the nerves come out. This is outlining where the nerve is coming out of the hole. And then we shoot some steroid in there to help reduce the inflammation there. I'll just show you a quick little video again. Has anyone had injections before here? No? This will be good then.
Lumbar transfemoral epidural steroid injection. This outpatient procedure is an injection of a steroid anesthetic medication. The medication can reduce swelling and inflammation of irritated spinal nerves. This procedure is performed to relieve pain in the lower back and pain that radiates from the back to the legs. The injection takes only a few minutes to complete. In preparation for the procedure, the patient lies face down. A cushion is placed under the abdomen, which causes the spine to bend in a way that opens the spaces on the sides of the spine. These spaces are called the foramina. A local anesthetic is administered to numb the skin and the tissue that covers the spine. When the area is numb, the physician carefully guides the needle into the foraminal space that surrounds the irritated nerve root. A contrast solution is injected through the needle. The physician uses a fluoroscope, a type of X-ray device, to confirm that the tip of the needle is positioned correctly. After the needle's position has been confirmed, the physician injects a steroid anesthetic medication. This medication bathes the irritated nerve roots. It will help alleviate the patient's pain. When the procedure is complete, the physician removes the needle and bandages the insertion site. The patient may feel significant relief after one injection. Some patients may need multiple injections before they feel the full benefit of the medication.
So in general, epidural steroid injections are a commonplace treatment. That's our bread and butter. We see patients day in and day out for these kind of injections for the neck and the back. It's endorsed by the North American Spine Society, by our surgeons, as well as our general practitioners. In a large study that was done, or a significant study that was done in the past, they had 55 patients with severe sciatica from disc herniation. In the placebo group, meaning the ones that didn't get the epidurals, 70% of them required surgery after 2 years. In the ones that did get epidural steroid injections, only 20% required surgery. And in follow-up after 5 years showed that 81% or 80% of the patients that had the injection still did not require surgery. The steroid injections don't necessarily fix the problem. It's not going to stop the degeneration to occur. It's not going to cause your disc to plump up or anything like that, or the herniation to go away. It allows you to get time. So our spines are dynamic, so things move and change, and things can reduce in size. Our core strength can get better, and all these things can align things up better, and so the nerve gets out of the way. So epidural steroid injections help to prevent the constant continuation of worsening nerve problems, and that's why we get this good benefit. Now, if you don't get improvement after 1 or 2 injections, and the injections don't last for 3 months or greater, that's when we look at surgical options, because although safe to do forever, if they're not working, they're not working. The next thing I want to talk about is sacroiliac dysfunction. So I forgot to bring the model this time, but basically the sacroiliac joint is here. This is your back of your spine. This is your pelvic, your hip. And your sacroiliac joint is the one that connects your sacrum, the bottom of your spine, to your hip. That can be inflamed and irritated for multiple different reasons. This is looking at it from the side view. This is your hip, and your joint is right there between your sacrum and the hip here. Its function is basically to stabilize your pelvis. It takes all the load from your upper body, and then it dissipates it to your lower body. So it's the strongest joint that we have in our body, but it can also cause pain. So a lot of times people injure this when they have falls or jumps where they land straight footed, or if they're in a car accident and they're bracing with their leg, because you're just looking for torsion that causes that sprain to happen. You can get a sprain of the ligaments that attach the sacrum to the ilium, or you can actually have arthritis in the joints that happen. So this is usually worse with long-term sitting, also crossing your legs and going up steps. These things can aggravate your SI joint. Sometimes patients that have had leg length discrepancies can cause SI joint problems. And the ones we see most often is anyone who's had a fusion of the lower lumbar spine. The weight load dissipation then goes into the sacrum, and a lot of people with fusions end up with sacroiliac dysfunction. So for this, again, medications, physical therapy, bracing the joint, and then what we do. So one, we can do steroid injections into the joint space as well, just like we do steroid injections for the knee if you have arthritis, or the shoulder if you have arthritis, we can do that. We can burn the nerves just like we did for the facet joint, but now we can do the same thing for the sacroiliac joint. So there are nerves that go to these joints, and we can knock those out. Peripheral nerve stimulation, which we touched upon before, that's another option that we have for long-term treatment. And then the final thing is SI joint fusion. So just like you fuse your spine, we do a fusion of the SI joint, but it's not an open surgery. It's done with incisions that are this big. You just stick a trocars through, which are steel rods that go straight through, not steel titanium, but they go through and they fuse this joint so it doesn't move. And those are all things that we do. This is just an example of what the joint looks like normally. There's a needle there, put some dye in it, outlines the joint. That means we're in the joint space, and then we put the steroid in after that. The last thing is spinal stenosis. You probably heard of people that have stenosis of the spine, and all that means is narrowing of the central canal of the spine. So your spinal cord here is in yellow, and then you see here it's nice and big, and down here it's getting all squished. It can get squished for lots of reasons, from arthritis from the sides, swelling of a ligament in your back, and disc bulging from the front. So all three of those things combine, and they cause narrowing of the canal. When that happens, the spinal cord gets flattened and it gets upset and angry. And the way to fix it is naturally from our body is to bend forward. That opens up the space. So you see a lot of people that have stenosis that have to bend forward, and they gradually do that over time because it helps alleviate the pain in their back. Also, by holding on, we call it the shopping cart sign, where if you have trouble walking, but you can walk a lot further when you're just on a shopping cart in the mall, and that is a sign of stenosis. The other thing is when your pain occurs when you stand or walk, and then it goes away when you sit. If that happens, that's a kind of a clear sign for spinal stenosis. And when you have spinal stenosis, like here's your spinal cord in the white, that's your spinal fluid. You see these little outbursts of discs here, and here's the ligament. This little spot here is way narrower than the spot up here, and that's where you're having stenosis. It improves, like I said, leaning forward, stooping forward. Patients that have this have pain really only when they stand and walk. They have very limited walking tolerance, so they can walk a block or less. And as soon as they walk and they sit down, they feel better, and then they can stand back up and walk a little further and keep doing that. And that's one of the big things here. Usually worse with bending forward, improve with bending forward. Bending backwards and improve forward. Again, we start with medications. This time a lot more nerve medications. We talked a little bit about some of the medicines that we tried, like pregabalin, gabapentin, duloxetine, these different drugs that we use that aren't narcotics. I forgot to mention we are really anti-opiates here unless you have a true reason to be on chronic opiate therapy. Back pain and neck pain have never been shown to have long-term improvement with usage of opiates. Anyway, physical therapy, and then we can do epidural steroid injections like we talked about, reduces swelling and around the nerve, and then that way opens up the space. And then this is something that we're doing now, offering this as surgical options. So it's called minimally invasive lumbar decompression. It's an acronym for that is mild procedure. So it's not major surgery. It's not open fusions. It's not laminectomies, but we are removing bone and a little bit of, I showed you this before. Okay, so we are removing a little bit of bone and the ligament in the back of the spine. So here's the front, this is your disc. Here's the trocar, this is the trocar coming in. This portion here is your ligament that's swollen. So with this little cannula, I can come in there and scoop out some of the bone and tissue here to open up the spine from the backside. It's a newer procedure. It's only, the incision site is the size of a pencil eraser. That's the only thing you'll see after that. We come in with this trocar, pull out the tissue, and then you go home the same day. It takes about an hour to do. And the studies have shown 80% improvement of back pain for more than 2 years, and the studies are now going out to 5 years. So this is an option for people that have stenosis. Either they're too sick to have big surgeries, or they don't want to have a bigger surgery like a fusion or stenosis. And I'll show you that right there. Okay.
Mild procedure. This procedure treats lumbar spinal stenosis. That's a narrowing of the space around the spinal nerves in your lower back. The mild procedure makes more room for these nerves, relieving painful compression. To begin, you lie face down. You're given medicine to help you feel relaxed. Your lower back is numb. With the help of a fluoroscope, that's an X-ray device that shows video images, a needle is carefully guided into your spinal canal. Contrast dye is injected into this space. It shows a clear view of the compression. Next, a small opening is made in your skin. The surgeon inserts a hollow tube called a portal and carefully pushes it down to your spine. Thin instruments are placed through this portal. The surgeon uses them to remove small bits of bone and overgrown tissue from the part of your spine that forms the rear of your spinal canal. This relieves pressure in the spinal canal. It gives your nerves more room. When the procedure is done, your skin is covered with a small bandage. You will be monitored for a brief time, and then you can go home. Your healthcare provider will give you tips to help your recovery.
So the good thing about this procedure is that the recovery time is like 1 day, and you can resume like your regular activities the following day. This is another procedure that we do, minimally invasive for stenosis. Put in a spacer in between your spinous process, and how we bend forward, we open up the spaces in the back of the spine when we bend forward. This does it for you just at one level. If you stick this in and open up the spaces, it's like you're bending forward, but we're just doing it for the space that's stenotic. That's called a vertiflex interspacer. So what do you do if you've already had spine surgery? I don't know if you guys have had any kind of neck or spine surgery, but if you have, there are people that have pain continue after surgery, which is very common. Only about 50% of back surgeries actually come out positive. It's 50%, so it's a crapshoot. We know that, and that surgeries usually last for about 5 years. So if you do have a fusion, it's usually about a 5-year term, and then usually something else above or below the area can get disrupted. So there's a syndrome for it because it happens so often. It's called failed back surgery syndrome or post-laminectomy syndrome, and there's actually a diagnosis code for that, just like there is for diabetes. So this is back and leg pain that continues despite surgery. Usually it's because some sort of scar tissue has formed in the area, causing continued nerve pain or pain in the spine. And there's other reasons why it happens. But either way, there's something that can be done, and it's called a spinal cord stimulator. So we talked a little bit about peripheral nerve. This is now central nerve. So now we're looking not to stimulate the nerves that are going down like carpal tunnel, but now we're stimulating the nerves coming here in the spine. This is a minimally invasive procedure where I thread these little leads into the spine. And let's say you're having back pain. This also occurs for your neck too. So we can do it for your neck or your back. But if you're having back pain going down the leg, I put the little needle here and thread the electrode all the way to the top in the middle of your back. When it's in the middle of your back, all your nerve signals that come from your lower legs in your back have to travel through your spinal cord to your brain before we say ouch. So these electrodes intercept that signal here in your middle of your spine, and change the way that the brain perceives that pattern by changing the electrical signal as it goes up into the brain. So it's an outpatient procedure, and the good thing about these stimulators is that you don't have to have any incisions done. You get to do a trial first. So you go home for 5 to 7 days with this thing, with the leads in your back, and then we put a little generator on your outside of your skin. We tape it all up. You go home with a remote control, and you see whether or not your pain is improved for those 5 to 7 days. If it's significant improvement after that trial period, then we take it out, no incisions, no pain. And then we have you come back and we actually do the implant. So it's the same thing, but instead of putting this little generator on the outside of your skin, I make a little incision and put the pacemaker battery inside underneath the skin. And we also do a small cut down here. So instead of anchoring the trial to your skin with tape, we put it underneath the skin and tie it to fascia so it stays permanent. That's called a permanent implant. The battery that we put in there, you last usually for 10 years. So at 10-year time, you come back and we just open up that little battery pack and put a new one in there. But like I said, the best thing about this is that they have a trial. So you can do it at home before you get an actual minimally invasive surgery. For stimulators, the 5-year data shows superior results in having repeat surgery. That's why Medicare approves it. That's why the FDA and the CMS all like this idea better than having a repeat spinal surgery. And I'll show you this is the last one. I think I'll show you this and we'll take a few questions.
Spinal cord stimulator implant. Spinal cord stimulation, also called SCS, uses electrical impulses to relieve chronic pain of the back, arms, and legs. Here's the lead. The electrical pulses prevent pain signals from being received by the brain. SCS candidates include people who suffer from neuropathic pain and for whom conservative treatments have failed. The injection site is anesthetized. One or more insulated wire leads are inserted through an epidural needle or through a small incision into the space surrounding the spinal cord, called the epidural space. Electrodes at the end of the lead produce electrical pulses that stimulate the nerves, blocking pain signals. The patient gives feedback to help the physician determine where to place the stimulators to best block the patient's pain. The leads are connected to an external trial stimulator, which will be used for approximately 1 week to determine if SCS will help the patient. If the patient and physician determine that the amount of pain relief is acceptable, the system may be permanently implanted. At the end of the trial implantation, the leads are removed.
And this is just the implant, but I won't put the only difference is that instead of that little thing that was on the side, we put that internally, and then you get a programmer to go home with, and you have full support with the representative of the spinal cord stimulators. There's tons of different companies. Each one does something different, but you have all the service to figure out. It's not as complicated as we think by using phones. It's just a simple device that helps you go up and down on the parameters. So we find this to be really helpful for people that have had surgery, or there's indications now for diabetic neuropathy as well too. So people that have diabetic neuropathy, this is another treatment for them. So just in conclusion, we talked a little bit about back, and sorry, didn't do too much about neck. I didn't really realize the title said neck pain on until I got here earlier today. I was like, oh, there's neck pain. Yeah, but everything applies for neck pain too. So, I went over like multiple treatment options from just the basic conservative stuff, from medication, physical therapy, and then we're moving on to minimally invasive procedures. And that's what we do, is minimally invasive things that can help you instead of having big giant surgeries. Even if you have giant surgeries, you can come back and still get treatment for pain with us. And this is, a lot of people, when they hear of a pain doctor or a pain specialist, they think of, oh, well, this must be somewhere where I can go get my pain pills or something. That's not what we do. And so we feel that the pain management algorithm for referrals should happen right after primary care. So primary care docs, if you go there and you say, my back hurts, my neck hurts, my arm hurts, my shoulder hurts, they should send to us, or you can come directly to us. So you don't need a referral to see us. You can come directly, or if you have friends that have pain, just tell them to come get a consult. If we can help someone, we can. If we can't, not a big deal. All types of pain, and we didn't talk about all this, but we treat everything from headache pain to foot pain, for all the way from top to bottom. So you have some sort of pain, we can either treat it, or we can send you to a specialist that has, we think it's surgical, bigger, then we send it that way. But it's kind of a one-stop shop. We provide all the ancillary services that you need, including imaging, therapy. We send out for pain psychology, mental health, and then we do injections either in the office or in the operating room. And then I do my bigger procedures in the operating room too. So, and we'd like to get to the pain first before it becomes chronic. So 3 weeks or so after you start your therapy maybe, or start some medications, if you have some new pain and it's not getting better within 3 weeks, you need to do something about it. The longer we sit on it, it becomes chronic. And like I said, it stops from being structural, then becomes non-structural, and it starts to go in your spinal cord and brain and becomes permanent. So that's where we want to make sure and get to the source of the treatment before we get a problem. Earlier to refer, the easier to treat. And that's really about it. Brittany was in the back, but I'm sure she grabbed some food. And so she's our lead. So if you have any questions, you can call. But yeah, I'll take some questions if you guys have any questions.